Every second of your life, your arteries experience a repeating cycle of pressure. The pressure rises when the heart pushes blood forward. Then it falls while the heart relaxes and refills. Those two moments create the two numbers you see on a blood pressure reading. My name is Dr. Warren Hung. I'm a medical doctor, and on this channel we take complicated health questions and slow them down until the underlying physiology becomes clear. Today's question looks simple, but it causes a lot of confusion. When you measure your blood pressure, you see two numbers. One is on top, one is on the bottom. Most people assume both numbers carry the same meaning. But from the perspective of long-term cardiovascular risk, especially heart attacks, those two numbers do not behave the same way inside the body. To understand why, we first need to understand what each number actually represents inside your arteries. Let's start with the top number. The top number is called systolic pressure. Systolic simply means the moment when the heart muscle contracts and pushes blood out into the arteries. The left side of the heart sends that blood into the largest artery in the body, the aorta. From there, blood moves into smaller arteries that carry oxygen and nutrients to every organ. During that contraction, pressure inside the arteries briefly rises. That peak pressure is the systolic number. If a reading says 120/80, the 120 is the highest pressure the arteries experience when the heart squeezes. Now let's look at the second number. The bottom number is called diastolic pressure. Diastole is the opposite phase of the heartbeat. It is the moment when the heart relaxes and refills with blood before the next contraction. During this time, the heart is not pushing blood forward, yet blood is still moving through the body. Why? Because the arteries themselves act like elastic tubes. When the heart pumps, the artery walls stretch slightly. Then, as the heart relaxes, those stretched walls recoil and help keep blood moving forward. The pressure that remains in the arteries during this resting phase is the diastolic pressure. If the reading is 120/80, the 80 represents the pressure inside the arteries, while the heart is resting between beats. So now we have two different measurements. The systolic number shows the peak pressure created by the heart's contraction. The diastolic number shows the baseline pressure that remains in the arteries between beats. Both numbers describe the same circulation system, but they capture different moments of the cardiac cycle. One is the pressure spike. The other is the background pressure. For decades, doctors debated which of these numbers mattered more. Earlier in the 20th century, many physicians focused mainly on the diastolic number. At that time, it was believed that the baseline pressure between heartbeats told us more about long-term stress on the arteries. But as long-term studies followed people for many years, researchers began noticing a pattern. In many adults, especially after middle age, the top number often carried more information about cardiovascular risk. That observation did not come from theory. It came from decades of population data. Large studies, such as the Framingham Heart Study, which began in 1948 and followed thousands of participants over generations, showed that blood pressure patterns change as arteries age and stiffen. As arteries lose elasticity, the systolic pressure tends to rise more sharply, while the diastolic pressure may remain stable or even fall. This creates a widening gap between the two numbers. Doctors call this difference pulse pressure, which simply means the distance between the systolic and diastolic readings. That widening gap turns out to matter for cardiovascular risk. But understanding why requires looking at what actually causes a heart attack in the first place. Because blood pressure itself does not directly cause the heart muscle to stop working. Instead, heart attacks develop through a long process inside the coronary arteries that supply blood to the heart muscle. And blood pressure plays a role in that process in ways that are not immediately obvious. But before we decide which blood pressure number predicts heart attacks more reliably, we first need to understand what actually happens inside a coronary artery during a heart attack. A heart attack does not begin with the heart suddenly failing. In most cases, the problem begins inside the arteries that supply blood to the heart muscle itself. These vessels are called the coronary arteries. They sit on the surface of the heart and wrap around it like small branches on a tree. Their job is simple. They deliver oxygen and nutrients to the heart muscle so it can keep pumping. If blood flow through one of these arteries becomes blocked, the heart muscle downstream begins to suffer from a lack of oxygen. Doctors call this ischemia, which simply means that tissue is not receiving enough blood. If the blockage lasts long enough, part of the heart muscle can begin to die. That is what we call a heart attack, or in medical terms, a myocardial infarction. But the blockage does not appear suddenly out of nowhere. It usually develops slowly over many years. Inside the wall of an artery, the inner lining is normally smooth. Blood cells pass through without sticking to it. Oxygen and nutrients flow freely. But when the artery wall experiences repeated stress or injury, the body begins a repair process. One of the major stresses on the artery wall is blood pressure. Every heartbeat pushes blood against the inside of the arteries. Over time, if that pressure is higher than normal, the force against the artery wall increases. You can think of it as water moving through a hose. If the pressure inside the hose increases, the wall of the hose experiences more strain. Arteries are living tissue, so they respond to this strain. Small areas of damage can appear in the inner lining of the artery. Doctors call this lining the endothelium. The endothelium is a very thin layer of cells that controls how blood interacts with the vessel wall. When the endothelium becomes injured, cholesterol particles traveling in the bloodstream can begin to slip beneath that layer. The type of cholesterol most involved in this process is LDL cholesterol. LDL stands for low-density lipoprotein. It is one of the particles that carry cholesterol through the bloodstream. When LDL particles accumulate beneath the artery lining, the immune system treats them as a problem that needs to be cleaned up. Immune cells move into the area and begin trying to remove the cholesterol. Over time, this interaction between cholesterol particles, immune cells, and artery tissue forms a structure called a plaque. A plaque is essentially a deposit inside the artery wall made of fats, immune cells, connective tissue, and calcium. At first, plaques may not block the artery very much. Blood can still flow around them. This is why people can have plaque inside their arteries for many years without symptoms. However, the presence of plaque makes the artery wall more vulnerable. The plaque has a surface layer called a fibrous cap. This cap separates the plaque from the blood flowing through the artery. If that cap remains stable, the plaque may remain relatively quiet. But sometimes the cap becomes weak. When that cap tears or ruptures, the contents of the plaque are suddenly exposed to the bloodstream. The body reacts to this exposure as if a blood vessel has been injured. Platelets, which are small cells involved in clotting, rapidly gather at the site. A blood clot begins to form. If that clot grows large enough, it can suddenly block the artery. When that happens in a coronary artery, the heart muscle supplied by that vessel loses its oxygen supply. That is the moment a heart attack occurs. Researchers have studied this process for decades. Large population studies, such as the Framingham Heart Study and the InterHeart Study, which examined heart attack risk factors across many countries, consistently show that several conditions accelerate plaque formation and plaque instability. These include smoking, diabetes, abnormal cholesterol levels, and high blood pressure. Blood pressure contributes to this process because it increases the mechanical stress placed on the artery wall over time. Higher pressure means stronger force pushing against the endothelium with every heartbeat. Over thousands of heartbeats each day and millions each year, that force influences how quickly artery damage develops. But there is an important detail. The force inside the arteries is not constant. It changes throughout the heartbeat. At one moment, the pressure spikes when the heart contracts. At another moment, the pressure settles to a lower level while the heart relaxes. That brings us back to the two numbers on a blood pressure reading. The systolic number reflects the peak force during each heartbeat. The diastolic number reflects the resting pressure between beats. Both of these pressures interact with the artery wall. Both can influence how plaques develop over time. Yet decades of cardiovascular research have asked a very specific question. If we follow large groups of people for many years, and we look at who eventually develops heart attacks, which of these two numbers tracks that risk more reliably? Answering that question required long-term population data and careful analysis of cardiovascular outcomes. And when those studies were examined together, a clear pattern began to appear. But to understand that pattern, we now need to compare systolic and diastolic pressure directly and see how each one relates to the long-term prediction of heart attacks. When doctors say a measurement predicts risk, they are not saying it guarantees an outcome. Prediction in medicine means something more specific. It means that when researchers follow large groups of people for many years, certain measurements consistently appear more often in the group that later develops a particular disease. Blood pressure has been studied this way for decades. Researchers have asked a straightforward question. If we measure blood pressure in thousands of people and then follow them over time, which number is more closely linked with future heart attacks? The top number, the systolic pressure, Across many long-term population studies, systolic pressure tends to track heart attack risk more strongly than the diastolic number, especially in adults over about age 50. This pattern has appeared repeatedly in cardiovascular research. One of the most influential sources of evidence comes from the Framingham Heart Study, which began in 1948 and followed several generations of participants in Massachusetts. Investigators, including Dr. William Cannell, one of the early leaders of the study, showed that systolic pressure became a stronger predictor of cardiovascular events as people aged. Later analyses of Framingham data demonstrated that systolic blood pressure was more closely associated with coronary heart disease and heart attack risk than diastolic pressure in middle-aged and older adults. The same pattern appears in large national data sets, such as NHANES, the National Health and Nutrition Examination Survey in the United States. When researchers examine cardiovascular outcomes in these populations, systolic pressure consistently shows a strong relationship with heart disease risk. Clinical guidelines reflect this evidence. Organizations such as the American Heart Association, AHA, and the European Society of Cardiology, ESC, classify hypertension primarily using the systolic number as the dominant signal of risk, particularly in older adults. But why does the systolic number matter so much? To understand that, we need to look at what happens to arteries as people age. Healthy arteries are elastic. When the heart pumps blood forward, the artery walls stretch slightly. This elasticity absorbs part of the pressure generated by the heart. After the heartbeat passes, the artery walls recoil and help push blood forward. This elasticity acts as a natural shock absorber for the circulatory system. But over time, arteries gradually become stiffer. Several processes contribute to this change. Calcium can accumulate in artery walls. Structural proteins inside the vessel wall slowly change. Long-term exposure to high blood pressure itself can remodel the artery wall. As arteries stiffen, they lose some of their ability to stretch. When the heart pumps into a stiff artery, the pressure spike becomes higher. This raises the systolic pressure. At the same time, the artery wall does not recoil as effectively during the resting phase of the heartbeat. This can cause the diastolic pressure to stay the same or even decrease slightly. The result is a widening gap between the two numbers. Doctors call that gap pulse pressure. Pulse pressure is simply the difference between the systolic and diastolic readings. For example, if blood pressure is 120/80, the pulse pressure is 40. If blood pressure becomes 160/70, the pulse pressure widens to 90. That widening reflects stiffer arteries and stronger pressure waves moving through the vascular system. And those pressure waves influence how much mechanical stress is applied to the artery walls, including the coronary arteries that supply the heart. Because of this, systolic pressure tends to capture an important part of the risk picture: the peak mechanical force acting on artery walls. Over many years, higher peak pressure contributes to endothelial injury, plaque formation, and plaque instability. This is one reason systolic pressure shows a strong association with heart attack risk in long-term studies. However, this does not mean the diastolic number is irrelevant. Diastolic pressure reflects the baseline pressure inside the arteries between heartbeats. If that baseline pressure becomes very high, it also increases stress on the artery wall and can contribute to plaque development. Earlier research in younger populations showed that diastolic hypertension could strongly predict cardiovascular risk. For example, analyses from earlier decades of the Framingham Heart Study found that elevated diastolic pressure in younger adults was associated with higher rates of coronary heart disease later in life. So the relationship between the two numbers changes depending on the age of the arteries. In younger adults, arteries are usually more elastic. Because the vessels can expand easily, the systolic spike may not rise dramatically even when baseline pressure is elevated. In that situation, a higher diastolic pressure may carry meaningful information about long-term vascular stress. As people age and arteries stiffen, the pattern shifts. Systolic pressure begins to rise more dramatically, while diastolic pressure may plateau or fall. In this stage, the systolic number becomes the clearer signal of cardiovascular risk. This age-related shift is well documented in hypertension research and reflected in modern treatment guidelines. So if we answer the title question directly, the systolic blood pressure number, the top number, is usually the stronger predictor of heart attack risk in middle-aged and older adults. But that answer is not the entire story. because there are situations where the diastolic number still matters, and there are patterns of blood pressure where interpreting the numbers correctly becomes more complicated. Doctors see these patterns frequently. Some patients have high systolic pressure but normal diastolic pressure. Others have the opposite pattern, and sometimes the bottom number can even fall too low, creating a different kind of risk. Understanding these patterns requires looking at how blood pressure behaves in different stages of life and different cardiovascular conditions. But to interpret your own blood pressure reading correctly, we need to examine when the most important number changes and why that happens inside aging arteries. Earlier, we answered the main question of this video. In many adults, especially after middle age, the systolic blood pressure, the top number, tends to be the stronger predictor of heart attack risk. But blood pressure is not a single uniform condition. The meaning of a reading can change depending on age, artery stiffness, and the pattern of the two numbers together. This is why doctors rarely interpret a blood pressure reading by looking at one number in isolation. Instead, they look at the pattern created by both numbers. Let's examine several common patterns. Pattern 1, high systolic, normal diastolic. This pattern is called isolated systolic hypertension. A typical example might look like this: 160/80. The top number is elevated. The bottom number is within the normal range. This pattern becomes increasingly common with age. As arteries stiffen, they lose their ability to absorb the pressure wave generated by the heart. That pressure wave travels faster through stiff arteries and creates a higher peak pressure. This raises the systolic number. Meanwhile, the diastolic pressure may remain stable or even decline slightly because the arteries are no longer recoiling as effectively during the resting phase of the heartbeat. Large studies have shown that this pattern carries significant cardiovascular risk. Analyses from the Framingham Heart Study demonstrated that isolated systolic hypertension in older adults is associated with higher rates of coronary heart disease and stroke. For this reason, modern treatment guidelines from organizations such as the American Heart Association, AHA, and the European Society of Cardiology, ESC, emphasize controlling elevated systolic pressure even when the diastolic number appears normal. Now let's look at a different pattern. Pattern 2, high diastolic, normal systolic. This pattern might appear as 125/95. The systolic pressure is within the typical range. The diastolic pressure is elevated. This pattern is more often seen in younger adults. Younger arteries are usually more elastic. They expand easily when the heart pumps blood forward. Because of this elasticity, the systolic spike may not rise dramatically. But the baseline pressure inside the arteries between heartbeats can still increase. That increase raises the diastolic number. Earlier cardiovascular research showed that elevated diastolic pressure in younger populations can still signal increased long-term risk. In younger participants of the Framingham Heart Study, higher diastolic pressure was associated with greater likelihood of developing coronary heart disease over time. In other words, in younger arteries, the bottom number can still carry important information. Now there is another pattern doctors watch closely. Pattern 3, wide pulse pressure. This occurs when the gap between the two numbers becomes unusually large. For example, 170/60. The difference between those numbers is 110. That difference is called pulse pressure. Pulse pressure reflects how much the pressure rises during each heartbeat compared with the resting pressure between beats. A widening pulse pressure often indicates stiffer arteries. Research from large observational studies, including analyses from Framingham, has shown that wider pulse pressure in older adults is associated with higher cardiovascular risk. The widened pressure wave can increase mechanical stress on the artery wall and may influence plaque stability. But there is one more pattern that doctors pay attention to. Pattern 4, very low diastolic pressure. Sometimes the bottom number can become too low. A reading might look like this: 150/55. The systolic pressure is elevated. The diastolic pressure is unusually low. Why might this matter? Because the coronary arteries that supply blood to the heart muscle fill primarily during the diastolic phase of the heartbeat, when the heart muscle relaxes. If diastolic pressure falls too low, the driving pressure pushing blood into those coronary arteries may decrease. Some studies have suggested a phenomenon called the J-curve relationship, where cardiovascular risk may rise again if diastolic pressure falls below certain levels in patients with coronary artery disease. This relationship has been discussed in analyses from observational cohorts and clinical trials reviewed in hypertension guidelines, including reports cited by the European Society of Cardiology. However, the evidence around the exact threshold remains debated, and clinicians evaluate this situation individually, rather than using a strict, universal cutoff. So when doctors look at a blood pressure reading, they are not simply asking which number is higher. They are asking several questions at the same time. How old are the arteries? Are they stiff or elastic? Is the pulse pressure widening? Is the diastolic pressure unusually low? These patterns help physicians interpret what the numbers mean for cardiovascular risk over time. And there is one more important factor that can completely change how these numbers are interpreted. That factor is measurement accuracy. Because if the measurement itself is wrong, the entire interpretation can become misleading. But before anyone concludes that one number is dangerous, we need to understand how blood pressure measurements can easily be distorted by common mistakes during testing. A blood pressure reading looks precise. Two numbers appear on the screen of a monitor, often within a few seconds. Because the numbers look exact, it is easy to assume they always represent the true pressure inside the arteries. But blood pressure is one of the most measurement-sensitive values in medicine. Small mistakes in how the measurement is taken can change the reading enough to make one number appear more important than it actually is. Before doctors interpret whether systolic or diastolic pressure carries risk, they first ask a different question. Was the measurement done correctly? Let's look at several common traps that can distort the numbers. Trap 1. The wrong cuff size. The inflatable cuff placed around the arm must match the size of the arm. If the cuff is too small, it compresses the artery more aggressively, and the monitor may report a pressure that is higher than the true value. If the cuff is too large, the reading can appear lower than it actually is. Clinical research evaluating blood pressure measurement techniques has shown that incorrect cuff size can change readings by 10 millimeters of mercury or more. That difference can move someone from a normal range into a hypertensive range. Guidelines from organizations such as the American Heart Association recommend selecting a cuff size that covers about 80% of the arm circumference for accurate measurement. Trap 2. Arm position. Blood pressure monitors measure pressure relative to the level of the heart. If the arm is positioned too low, gravity increases the measured pressure. If the arm is raised above heart level, the reading may appear lower. Studies examining blood pressure measurement technique show that arm position differences can change readings by 5 to 10 millimeters of mercury. For accurate readings, the arm should rest comfortably on a table so the cuff sits at the same level as the heart. Trap 3. Talking during the measurement. Blood pressure is influenced by the nervous system. Talking activates muscles and stimulates parts of the nervous system that can raise blood pressure temporarily. Clinical observations reported in hypertension measurement studies show that talking during a measurement can increase systolic pressure by around 10 millimeters of mercury. For this reason, standard measurement protocols recommend remaining silent and still during the reading. Trap 4. Recent caffeine, nicotine, or exercise. Blood pressure fluctuates throughout the day. Caffeine can temporarily raise blood pressure by stimulating the cardiovascular system. Nicotine causes blood vessels to constrict, which can also raise pressure. Exercise increases heart rate and blood flow, which can elevate readings temporarily until the body returns to its resting state. Measurement recommendations from the American Heart Association suggest avoiding caffeine, nicotine, and exercise for at least 30 minutes before measuring blood pressure to obtain a resting value. Trap 5. The white coat effect. Some people experience a temporary increase in blood pressure when measured in a medical setting. This phenomenon is called white coat hypertension. The stress response triggered by a clinic visit can activate the sympathetic nervous system and increase blood pressure for a short period. Researchers have studied this pattern using both clinic measurements and home monitoring. Data from NHANES and other observational studies show that some individuals have elevated readings in medical offices but normal blood pressure at home. Because of this, many clinicians recommend confirming high readings with home blood pressure monitoring or ambulatory blood pressure monitoring, which records measurements over a full day. Trap 6. Single measurements. Blood pressure naturally varies from moment to moment. A single reading provides only a snapshot. Clinical guidelines from the American Heart Association and European Society of Cardiology recommend averaging multiple readings taken on different days before diagnosing hypertension. This approach reduces the chance that one unusual reading leads to an incorrect conclusion. When these measurement traps occur, they can distort the relationship between systolic and diastolic pressure. For example, a measurement taken immediately after climbing stairs may temporarily raise the systolic number. A reading taken with the arm hanging down may artificially raise both numbers. This is why clinicians interpret blood pressure patterns over time rather than relying on a single number. Only after confirming that the measurement is accurate can doctors decide what the numbers actually mean for cardiovascular risk. And once accurate measurements are collected over weeks or months, a clearer picture begins to appear. Patterns emerge. Trends become visible. And those trends allow doctors to separate temporary fluctuations from the long-term pressure patterns that influence heart attack risk. But to make sense of those patterns, we need to step back and connect everything we have discussed: how arteries work, how heart attacks develop, and how blood pressure numbers behave over time. We began this discussion with a simple question. When you look at a blood pressure reading, which number predicts heart attacks? To answer that question properly, we had to slow down and look at several different systems. First, we examined what the two numbers actually measure. The systolic number shows the peak pressure created when the heart contracts and pushes blood into the arteries. The diastolic number shows the baseline pressure that remains inside the arteries while the heart relaxes between beats. Both numbers describe the same circulation system, but they capture different moments in the heartbeat. Next, we looked at what causes a heart attack. In most cases, a heart attack develops when plaque inside a coronary artery ruptures and a blood clot suddenly blocks blood flow to the heart muscle. Blood pressure contributes to this process because it increases the mechanical stress applied to artery walls over many years. Higher pressure can accelerate injury to the inner lining of arteries, allowing cholesterol particles to accumulate and plaques to form. Large population studies have helped clarify which blood pressure patterns track heart attack risk over time. Research from the Framingham Heart Study, along with analyses from NHANES and international cardiovascular cohorts, shows that systolic pressure becomes the stronger predictor of heart attack risk in many adults as arteries age and stiffen. That is why modern hypertension guidelines from organizations such as the American Heart Association and the European Society of Cardiology emphasize controlling elevated systolic pressure, particularly in middle-aged and older adults. But the systolic number is not the only signal. In younger adults with more elastic arteries, the diastolic number can still carry meaningful information about long-term vascular stress. And when the gap between the two numbers becomes large, something doctors call pulse pressure, that widening can signal increasing stiffness in the arteries. This is why clinicians rarely focus on one number alone. They look at the pattern created by both numbers together. They consider age. They consider artery stiffness. They consider whether the readings are consistent over time. Another important distinction is the difference between symptom control and risk regulation. High blood pressure usually does not cause immediate symptoms. Many people feel completely normal even when their pressure is elevated. The goal of blood pressure management is not simply to make someone feel different in the moment. The goal is to reduce long-term stress on the arteries and lower the probability of cardiovascular events many years in the future. That is why accurate measurement matters so much. Blood pressure should be measured carefully under resting conditions and repeated across multiple days. Only then can the pattern become clear enough to interpret. When that pattern shows persistently elevated pressure, whether systolic, diastolic, or both, it becomes important to address the underlying factors that influence blood pressure regulation. Those factors can include body weight, sodium intake, physical activity, sleep quality, alcohol use, medications, and medical conditions such as kidney disease or hormonal disorders. Working with a clinician allows these factors to be evaluated systematically. Treatment may involve lifestyle adjustments, medication, or a combination of both, depending on the individual situation and overall cardiovascular risk. So, if we return to the original question one last time, which blood pressure number predicts heart attacks? In many adults, especially as arteries age, the systolic number, the top number, tends to carry the strongest predictive signal. But the real lesson is not that one number matters and the other does not. The real lesson is that blood pressure is a long-term pattern inside the arteries, and that pattern tells a story about how the cardiovascular system is changing over time. Understanding that pattern and addressing it early is one of the most effective ways to reduce the risk of heart disease later in life. If you want to continue learning how everyday physiology shapes long-term health, That is exactly what we explore here on We Care Health with me, Dr. Warren Hung.